I'm Elliot Shearer. I'm a attending physician at Boston Children's Hospital and an assistant professor in otolaryngology, head and neck surgery at Harvard Medical School. And I am a cochlear implant surgeon at Boston Children's Hospital, and I also have a lab that studies genetic hearing loss. Both my clinical and my research interests focus on children with hearing loss. And so what that means is in clinic, I see children with all different types of hearing loss, and I help treat them in various ways using hearing aids, cochlear implants. Some of my patients just use sign language for communication. It's all per patient preference. My lab studies genetic hearing loss in children. What makes genetic hearing loss so interesting, but also so very difficult to study, is that there are more than 120 different genes that cause genetic hearing loss. Plus, there's hundreds more that cause syndromic hearing loss, which is where you have hearing loss plus other clinical features or symptoms. So hearing loss and vision problems like Usher syndrome, or hearing loss and thyroid problems like Pendred syndrome. And within these genes, there's thousands of reported pathogenic variants. And so really what we're finding is that hearing loss in children and genetic hearing loss is not just one single genetic disorder, but really thousands of different disorders. And so this is what makes studying genetic hearing loss so interesting, but also so difficult. Through my PhD work, I helped to develop a massively parallel sequencing panel, or next generation sequencing panel, for hearing loss. And it's been a lot of work to get where we are today, which is in the majority of children, we're able to identify a genetic cause of hearing loss, which we weren't able to do 10 or 15 years ago. And with respect to cochlear implant outcomes and genetics, I've been studying that for years, just because as a cochlear implant surgeon and as physicians, we always like to highlight the successes of our treatments or our therapies, but we also need to keep in mind that some children and also some adults don't do as well with cochlear implants as we would hope. And so the goal is that we can use genetics to try to identify individuals that may be at risk of not doing as well, and identify them before we perform surgery, so that we're best able to counsel them and then set up therapy for them afterwards. Cochlear implants and genetics is really important, because right now all we have to go from when I see a patient and we're planning for a cochlear implant is their hearing test or their audiogram. But really that's a very low fidelity test, and it doesn't give us a great idea of how they're going to do after cochlear implantation. And so I and others would really like a better test that we're able to provide before surgery, so that we're better able to counsel them for their post-operative course, identify the individuals that may not perform as well as others preoperatively, so that we're able to set up therapy afterwards and make sure they get sort of treatment focused to their form of genetic hearing loss. So a typical day for me completely varies based on the day. So I'm a surgeon and a scientist. So some days I'm in the operating room doing cochlear implants. Other days I'm in the operating room doing other surgical cases that any other pediatric otolaryngologist would do. And then some days I'm in clinic seeing patients, and other days I'm in the lab with my team. And I couldn't do what I'm doing today without my team, because I'm not able to be in the lab 100% of the time. So I've been able and been very fortunate to create a team that is able to complement all the different parts of my work that I do. So for instance, I work with a really fantastic genetic counselor in lab as well as in clinic, and she helps coordinate our patient research studies. And then I have a group that's in the lab doing more basic science research focused specifically on hearing loss caused by one gene called TMPRSS3. And we have mouse models of that hearing loss, and we're trying out new therapies for that mouse, specifically gene therapies for that gene in that mouse. And so really research in my lab spans sort of bench to bedside, where we have clinical studies involving children who have hearing loss, and then we have mice in the lab that have hearing loss. And some days I'll go from the OR to the lab to the clinic, and I think those are the days that I really enjoy the most and feel like I'm able to make the biggest impact. The most difficult part about studying genetic hearing loss is that there are so many different genes involved and so many different variants. And although we've made great progress over the past 10 or 15 years in improving our ability to diagnose genetic hearing loss in children, we're still not able to find a cause in probably about 40% of kids who we think truly do have a genetic hearing loss. And this has been a limitation of the testing methodology that we use. So short read sequencing, which is typically a targeted panel or an exome-based panel looking at all the different hearing loss genes. And so there's kind of a missing 40 or 50% of genetic hearing loss that we haven't identified yet. And this is a big roadblock because it prevents us from coming up with new therapies for these individuals and identifying new diagnostic tools, because essentially we've reached what I would say close to the end of the road for our ability to identify new hearing loss genes and new causes of genetic hearing loss using what is the most commonly used tool, which is short read targeted gene sequencing. Finding an answer, finding a diagnosis for genetic hearing loss is hugely important for the families. That's why we do all this work, and that's our primary goal. From a research perspective, it also is hugely important because it gives us an idea as far as the targets for the next clinical trials for gene therapy, what those should be, and the best ways that we can design gene therapies and molecular therapies to help individuals that have hearing loss. We have a large group of patients in my lab who have hearing loss that we think is genetic, and these individuals have typically undergone multiple forms of genetic testing. So some of these kids had single gene sequencing years ago when that was the only available option, using Sanger sequencing. And then many of them will have a commercial sort of gene panel test that comes up negative. And then when they enroll in one of our studies, the first thing we do is short read whole exome sequencing, and a significant percent of those individuals still end up being negative. We'll even proceed with short read whole genome sequencing and then continue to have a negative result. And what we were so excited about with our collaboration with PacBio is that we wanted to take those individuals who are negative for Sanger sequencing, exome sequencing, short read genome sequencing, and see if we were able to identify genetic variants that could be causing hearing loss. And in our initial set of 10 patients that we performed PacBio Hi-Fi sequencing on, we identified the genetic cause in 3 out of 10. And so an increase of 30% in our initial cohort might not seem like a lot to everyone, but to us it's huge, because each time that we're able to identify a genetic cause of hearing loss in these children, it really has huge implications for the patient and the family, who essentially have been searching for answers for years. I'd hope to do more PacBio sequencing. I think that we need to have new technology to push us further in understanding the genetic underpinnings of hearing loss. So we've kind of gotten the low-hanging fruit with short read exome and genome sequencing, but we need new technology like PacBio to advance us further to identify new genetic causes of hearing loss that we're just not able to see with standard technology.